the question is actually quite provocative. It's like, does this intensification with chemotherapy, does volume matter? And to make it short, yes, it does matter, but volume is not the only thing. So we know in metastatic hormone-sensitive prostate cancer, we have like made really big steps in the last years, because for really 40 years, we treated patients with ADT alone. And then first came actually the new studies adding chemotherapy with docetaxel to ADT, showing an overall survival benefit, as you probably know. And then, so now the question is, who's profiting from that? Because we have, in the meantime, seen that also addition of novel endocrine agents like abiraterone, like enzalutamide, like apalutamide, is giving you an OS benefit as well. Hazard ratio even looks a bit better. Tolerability is a bit better. So I guess, a lot of people, like, especially like when you talk to patients, most of patients, if they have this decision, go for chemotherapy or for a novel endocrine agent, would not go for the chemotherapy. And then in the meantime, we had also the data that addition of radiotherapy to the primary is giving an overall survival benefit, but only in the patients with low volume disease. So there it's very clear that volume matters. Whereas with the novel endocrine agents, they seem to really benefit everyone, at least as we can see now in the subgroup. So then, like now, when we thought we know everything, comes the triplet therapies with docetaxel plus a novel endocrine agent. And in that sense, for me at least, because we have this really clean data from our sense where all the patients had docetaxel and ADT in the control arm, and then you added darolutamide and there was an overall survival benefit, I think it's very hard to argue which patients you should treat now with docetaxel and ADT alone. So there, for me at least, but I know that not all my colleagues are okay with that. Also we did also that question in APCC, by the way. So still some people would think, no, you can give it to some patients, just adding docetaxel, nothing else. And I think they're really, all the questions are still open, right? But it seems that there is a subgroup of patients with low volume metachronous disease, so relapsing after radical treatment. And these patients have a very good prognosis. And that's in the meta-analysis that has been done with STOPCAP. It's called STOPCAP meta-analysis, a very important work, I think, just combining all the individualized patient data from the 3 trials that added docetaxel to ADT. And there you saw that these patients are different from the 3 other groups. So the low volume metachronous behave differently, and they don't seem to profit from docetaxel. The other groups do profit, seems to be a benefit, but also here the most benefit you have or has been seen in the patients with high volume synchronous de novo disease. So these groups, I think for the moment, we talked about the biomarkers before, since we don't have like real molecular biomarkers in the moment to help us with treatment decisions, these clinical parameters, low volume, high volume, de novo, or relapsed, are really helping us to make treatment decisions in a certain way.